Valvuloplasty is extremely important from the point of doing an intervention, because more than angiography, I think echo gives you a better overview of the whole lesion. So in balloon aortic valvuloplasties, these are all the things we should look before we go on to dilate the valves. So level of obstruction, etiology of valvular aortic stenosis, severity of obstruction, and measurement of annulus dimension, left ventricular function, and any other associated cardiac lesions. Aortic stenosis can be present with several other lesions. So the level of obstruction, subvalvular stenosis, can be either due to discrete subaortic membrane or due to fibromuscular narrowing of the left ventricular outflow tract. In HOCM, the thing is slightly different. It is a dynamic obstruction and refers to the obstruction developing predominantly in the mid and late systole, then results in late peaking velocity curve. So there we can see the subaortic membrane, and you can see the flow acceleration of blood through that particular area. The same thing, and you have to do it in different phases of cardiac cycle. There you can see, and the importance is the presence of the subaortic membrane in relation to the aortic valve. If they are very close to the aortic valve, it becomes very difficult for the surgeon to salvage this aortic valve, because they land up in a lot of times in damaging the aortic valve. So that information is very important, how close this subaortic membrane is to the aortic valve leaflets. And then whether the subaortic membrane is circumferential, that means it will be both anterior and posterior, or it is just anteriorly. So all these informations are very vital when you hand over these patients to the cardiac surgeons. And these are obviously not subsets for balloon angioplasty. This has to be dealt surgically. Supravalvular stenosis is also a subset of patients which cannot be dealt by balloon angioplasty, and typically seen in children with Williams syndrome with narrowing above the aortic root. And the narrowing can be due to discrete membrane, hourglass narrowing, or uniformly narrow ascending aorta. So that's the aortic valve, and we can find the supravalvular narrowing area in this particular area. So that's how you measure the whole thing. This is the valve root, and this is the supravalvular area. So etiology of valvular aortic stenosis now comes to the valve. Etiology is extremely important, whether it is a congenitally bicuspid aortic valve or it's an acquired rheumatic and calcified aortic valve. Valve anatomy should be measured from the parasternal long axis and short axis view. You should do a zoom mode and measure the valve anatomy. The valve annular size is a very important information, and that information has to be given by looking at the valve in a zoom mode, and it should be measured from hinge to hinge. I'll show you that picture. So you have to identify the number of cusps in systole and if there is any raphe present. You have to assess the cusp mobility and commissural fusion and assess valve calcification. So that's the picture of bicuspid aortic valve. We can see the two leaflets opening up. There's another picture of the bicuspid aortic valve. Now, the severity of obstruction, that's very important. The primary parameters recommended for evaluation of severity are the aortic stenosis jet velocity, mean trans-aortic gradient, and valve area by continuity equation. The first two are very important. We routinely, for balloon valvuloplasties, we routinely don't do continuity equation. So first we have to do a color wave, continuous wave Doppler, and there should be a good dedicated transducer for that. I mean, dedicated in the sense of the age and weight of the child. There should be multiple acoustic windows, like you have to take apical view, fourth chamber apical view, suprasternal view, and the right parasternal view is the view which gives you the best alignment of the valve to the outflow, I mean to the CW marker. So that's very important. The right parasternal view, turn the patient to slightly on the right side, and then take the gradient. It gives you a perfect alignment with the cursor. Decrease your gains, increase the wall filters, adjust the baseline and scale to optimize the signal, and so that you can get the best measurements. The velocity range and baseline adjusted so that the velocity signal fits, but it fills the whole vertical scale. These are very small, important points. And the maximum velocity at peak of dense velocity curve. Avoid noise and fine linear signals. The beginners often start measuring where the tip of the all frayed Doppler signals are there, but that is wrong. You have to get the dense velocity curve. The velocity VTI traced from outer edge of dense signal curve, and the mean gradient is calculated from traced velocity curve. And report the window where the maximum velocity is obtained. That's again a very important thing. And often in slightly adolescent children with slightly poor windows, try a right parasternal view before you give a final comment on the aortic stenosis gradient. So that's the CW flow. You can see the mean gradient being measured is about 67, and the max gradient is about 114, so it is a severe aortic stenosis. This is another very important point to note is the ventricular dysfunction. In very severe aortic stenosis, you often have severe ventricular dysfunctions, so that's an emergency and has to be dealt as soon as possible. These patients are younger patients, they are really acidotic, in shock, and they have to be dealt as soon as possible. So severity-wise, the AS jet velocity in meters per second about cutoff for is 4, and the advantage is a direct measurement of velocity, strongest predictor of clinical outcome. But the limitations are correct measurement requires parallel alignment of the ultrasound beam. That is very important to get a correct gradient. And it is always flow dependent. The mean gradient about 40 to 50 is called, beyond that is severe. So it is averaged from the velocity curve, units comparable to invasive measurements. And accurate, the limitations are of course, accurate pressure gradients depends on the accurate velocity data, and it is flow dependent. And with the continuity equation valve area, below 1 centimeter square is considered severe and measures effectively orifice area and relatively flow dependent. But limitations are requires LVOT diameter and flow velocity data along with aortic velocity. Measurement errors are more likely. Classification of aortic stenosis according to echocardiographic gradients. So mild is 2.6 to 2.9 meters per second. Moderate is 3 to 4, and more than 4 is severe. And mean, of course, 20 to 40 is moderate, and more than 40, and some says more than 50 is severe. There are different guidelines and different ways of calculating. So that's, you have to measure the valve annulus in different views, and not a single view will give you the right answer. So there you measure the valve, the root, and the connection, the ST junction. So this from hinge to the hinge, when you are measuring this, please do not look at what is being measured. That will bias you. So just don't look at this and just measure from hinge to hinge, and then in multiple views, and then get a final assessment what size balloon we are going to use. So there are few resolutions of apparent discrepancies in measurements of aortic stenosis severity. When the aortic stenosis velocity is more than 4 meters per second, but the valve area is also more than 1 square centimeter, then you have to check something somewhere is wrong. So check the LVOT gradient measurement and compare it with previous studies. Check LVOT velocity signal for flow acceleration. Calculate indexed aortic valve area and when the height is less than 135 centimeters, body surface area less than 1.5 meters square, and BMI less than 22. You also have to evaluate the aortic regurgitation severity and also evaluate for high cardiac output. So likely causes where the aortic stenosis velocity is more than 4 meters per second, but the area is also more than 1 square centimeter. Likely causes probably high output state, moderate to severe AR, or large BMI, large body size. In the reverse, if the aortic stenosis velocity is less than 4 meters per second, and so it is not so severe stenosis, but the area is also less than 1 square centimeter. In those, the likely causes are low cardiac output, small body size, or any severe MR. So these things we have to keep in mind before actually assessing the degree of severity. And post-balloon angioplasty echocardiography is very important. Even before we open our gloves after the procedure, we ask someone to look at the echo. There is a grade of aortic regurgitation, which is very important. And if it is beyond moderate, it is not very well tolerated. So you have to be extremely careful. But since we started using rapid right ventricular pacing to decrease the cardiac output so that the balloon doesn't jump too much, the incidence of aortic regurgitation has really come down or to almost negligible. And if you are okay with the balloon size, if you don't exceed 80 to 100% of the annulus size. Whether the LV function has improved, whether the mitral regurgitation has come down, and whether the PFO gradient has come, it takes time to come down with the improvement of the LV function. And this dilated aortic root is very important because it is often associated with bicuspid aortic valve, and especially as a disease continuum. So we need to take care of the dilated aortic root and give specific medicines needed for that. Next, we come to balloon pulmonary valvuloplasty. So same, by echocardiography, we see the level of obstruction, anatomy of valvular pulmonary stenosis, severity, annulus dimensions, right ventricular function, and associated cardiac lesions. So level of obstructions can be different, like valvular, infundibular, supravalvular, and even up to branch pulmonary artery stenosis, that is peripheral PS. So in classic pulmonary valve stenosis, this part we have a conical dome-shaped valve, few raphes. Less commonly, the valve may be diffusely thickened. Valve annulus size is usually normal, and usually there is a post-stenotic dilatation. But in dysplastic valves, we have like markedly thickened valves composed of disorganized myxomatous tissue. Valve annulus is usually hypoplastic. There is post-stenotic dilatation, and usually associated with some syndromes. So that's again hinge-to-hinge measurement of the pulmonary valves. This also has to be done in different views: parasternal short axis, long axis, and four-chamber apical views. So that's again in different views. This is a subcostal view of measuring the pulmonary valves. And this is a dysplastic valve. Again, you can see the valve leaflets are not really good looking. This color, CW signal is very important. This particular sickle shape is the infundibular component of the stenosis, and this tongue shape is usually the valvular component. So you have to assess how much degree of stenosis is at what level. Severity-wise, mild is less than 3 millimeters, and when it exceeds more than 4 meters per second, then it is severe stenosis. And peak gradients more than 64, that is 4 meters per second, it is considered severe stenosis. And you can always get the RV systolic pressure measurement by taking the TR gradient. And post-balloon angioplasty, again, you have to look for pulmonary regurgitation, usually well tolerated, and the RV function, whether it is improved, especially when you do slightly older kids with severe pulmonary stenosis, they usually have severe RV dysfunction associated. And blood flow direction in the PFO is very important, because in very critical stenosis, we often have PFO shunting right to left pre-balloon, and once you have dilated, gradually when the RV compliance, everything improves, the PFO direction changes. So that's important information. Thank you all, and I welcome you all to the Eastern India Pediatric Intervention Conference, EPIC, from 28 to 29 March in Calcutta. The website is there. Thank you.